so much for the kind introduction. The previous session I was attending to on nephrology, probably we found that there's a lot of emphasis on proteinuria. Now I'll be approaching in a different way. It's proteinuric to non-proteinuric nephropathy in diabetes paradigm shift. Now, diabetes mellitus and nephropathy is a pervasive cause of end-stage kidney disease in the Western population. Nephropathy affects 20 to 30% of type 2 diabetics in the Western world. Advanced renal disease attributable to diabetic disease accounts for 44% in USA and 30% in Europe. Epidemiological surveys unequivocally showed that a reduced GFR is more common among diabetic patients than in non-diabetic subjects, but also revealed that a large number of such patients will never show levels of proteinuria above the traditional definition of overt diabetic nephropathy during their life course. So this is the moot point which drew attention of the whole world. Now, many epidemiological and prospective studies have shown that tight blood glucose control prevents development of nephropathy, like DCCT and EQPDS, and reverses already existing nephropathy when it is in early stages of secondary prevention. Monitoring of blood pressure and proteinuria along with tight blood glucose should be practiced in every diabetic subject. Now, coming to this picture of diabetic nephron and altered renal hemodynamics, I beg to draw your kind attention. If you look at an uncontrolled diabetic state, there is severe hyperglycemia, high blood glucose amino acid levels, blood amino acid levels, and low sodium delivery to the macula densa. So this leads to vasodilation of the afferent arterioles, and there's increased sodium and chloride filtration and glucose filtration at the Bowman's capsule, and subsequently increased sodium chloride reabsorption and glucose reabsorption in the loop of annuli, and then decreased distal delivery of sodium chloride, which ultimately leads to vasoconstriction of the efferent vasoconstriction and high local angiotensin 2 levels, and vasodilated, the afferent is dilated, the efferent is constricted. And this is the classical thing which leads to a diabetic nephron. Now, coming to diabetic nephropathy in India, the earliest study was under the aegis of WHO in between 75 to 78, and Delhi was one of the centers, and they found in the duration of diabetes being between 0 to 6 years, the prevalence was 9.3 to 4.2 in male and females. Duration between 6 to 13 years was 10.7 and 5.7, and duration more than 14 years was 23% in males and 13.6% in females. And the significant albuminuria or the serum creatinine was more than 1.5 milligram per deciliter. Similarly, another study on mortality from AIMS showed that death due to renal causes was 22.7% in age 66, 28.2 in 76, and 40% in 1986. ICMR also showed similar prevalence of diabetes in the other parts of the country. Now, coming to the diabetic nephropathy study was observed to be 12.2% in males and 5.3% females in the first group, that is 0 to 6 years. It was a 9-center collaborative study under the ICMR. And between 6 to 13% was 18% in males and 8.7% in females. And those were more than 14 years to 22.8% males and 7.5% females, which is less than the previous study under the aegis of the WHO. Now, coming to the pioneering epidemiologic world by the Indian CKD registry by the Indian Society of Nephrology, diabetes mellitus was found to be the cause for CKD in 31.2% of cases. Now, coming to DKD, proteinuria, diabetic kidney disease. In an epidemiological study comparing secular trends in the prevalence of diabetic kidney in the USA across 3 time windows between 88 to 94, 99 to 2004, and 2005 to 2008, it was seen that albuminuria or albumin creatinine of 30 milligram per gram, reduced GFR of less than 60 ml per BMI meter square, both increased over the time. That is, from 88 to 94, it was 2.2. 99 to 2004 was 2.8 and reaching 3.3 in 2005 to 2008. But overall CKD increased from 14.9% to 17.7%, whereas albuminuria tend to decrease. So this is the moot point again, that in a longitudinal study in US they found that even if the prevalence of CKD is increasing, the prevalence of albuminuria is decreasing in patients with diabetic kidney disease. The observations, the same database extended up to 2014 revealed the prevalence of albuminuria decreased progressively over time from 20.8% to 1994 to 15.9% to 2009-14. In contrast, the prevalence of reduced EGFR increased from 9.2% to 94, 14.1% 9 to 14, and comparing to 2009 to 14 and 2009 to 88 to 94 to significantly high, suggesting that it is gradually what we are detecting is non-albumuric chronic kidney disease in diabetics. Well, this is a glycemic control vis-a-vis renal endpoints. All of us know about it. Just to brush our study memory, DCCT showed us when the glycemic control, when the HbA1c is about 7.33 versus 9.1, is reduced micro N over proteinuria. And EDICT and DCCT again showed that intensive versus standard glycemic, the renoprotective efficacy persisted with microalbuminuria risk in 45% at 18 years. UKPDA showed intensive versus standard glycemia. Again, those were HbA1 7 versus 7.9, risk reduction in microalbuminuria. Advance also came with similar studies. And thus it is clear that in albumuric diabetic nephropathy, tight glycemic control definitely helps in bringing down microalbuminuria or macroalbuminuria. Now, coming to Indian scenario, the Chennai Urban Rural Epidemiological Study, or the CURE study, revealed that overt proteinuria was found in 2.2% and microalbuminuria was found 26.9% in their study. The Chunampet Rural Diabetes Prevention Study also revealed that diabetic nephropathy was about 24.3% depending on microalbuminuria. Study from Bikaner and North India also showed that the clinic-based studies revealed that diabetic nephropathy was present in 26.8 and 15.3% respectively. The SENDI study done by our own colleagues in the multi-center study, it found that newly detected diabetics, the prevalence of microalbuminuria was 13.15%. Now, coming to the microalbuminuria in Indian subjects with type 1, type 2 diabetics, from Mumbai study, it was seen that in type 1 diabetics, microalbuminuria is more common in males, older individuals, and subjects with a longer duration of diabetes. Microalbuminuria was a marker of progressive diabetic nephropathy. On the other hand, if you look at in type 2 diabetics, here is a discordance. Microalbuminuria in type 2 diabetics was found to be a marker of generalized vascular endothelial dysfunction rather than pure diabetic nephropathy. In our study, we followed the same cohort of patients for 2 years. At entry in males and females, the urine protein was 2.2 to 80 to 190, and with good glycemic control, urine protein excretion came down to 90 milligram per deciliter and 80 milligram deciliter. So Chennai, the overt nephropathy was seen in 2.2% and microalbuminuria was seen in 26.9%. Thus, microalbuminuria and nephropathy in type 2 diabetes are not because of the same cause. Now, coming to proteinuria to non-proteinuric, the paradigm shift. Historical trends showing improvements in glycemic control over time in large databases and widespread use of antagonists of renin-angiotensin system may have contributed to decrease in prevalence of glomerular disease. Albuminuria is sine qua non of glomerular disease and allowed the emergence of other types of renal lesions affecting the interstitium and vasculature. That is, lesions that may cause progressive renal damage without triggering proteinuria or producing just mild to moderate increase in the levels of this biomarker. Now, coming to, as alluded to before, paradigm that proteinuria is a necessary step in the course of CKD associated with type 2 diabetes causing renal dysfunction and progressive ESRT has been reframed. Microalbuminuria in type 2 diabetic patient found to be a marker of generalized vascular endothelial dysfunction rather than a sole marker of diabetic kidney disease. and Dr. Agarwal from, from AIMS New Delhi have shown that 17.5% newly diagnosed diabetics had hypertension. So hypertension also is contributing to microalbuminuria as a part of generalized endothelial dysfunction. That's a very important cartoon. Two different phenotypes, proteinuric and non-proteinuric. The blue is the classical proteinuric phenotype, and these two are non-proteinuric phenotype. If you look at the proteinuric phenotype of chronic kidney disease and diabetes, the GFR fall and proteinuria has a very long history. By the time it becomes a frank proteinuria, the GFR also comes down, but at the middle stage, they may not be so much proteinuric and GFR is not low. But if you look at the non-proteinuric phenotype, those who are non-albuminuric, the fall of GFR is very rapid, and those who are having microalbuminuria, again, the GFR is more rapid than the classic phenotype. So reduction in eGFR occurs much earlier in the non-proteinuric phenotype than in the proteinuric phenotype. So International Diabetes Federation and the International Society of Nephrology, including about 30,000 type 2 diabetic patients from 33 countries, found that the overall prevalence of non-albuminuric, microalbuminuric, and macroalbuminuric was 51, 39, and 10% respectively, with wide racial differences. In the absence of proteinuria, a reduced GFR is observed in about 1 diabetic patient out of 5, 20% of patients. Proteinuria cannot be considered as a marker of diabetic nephropathy without quote. Rather, proteinuria in diabetics has to be seen as an indicator of glomerular disease lesion in diabetic patients with CKD. Coming to proteinuria is a distinguishing feature of primary and secondary forms of chronic glomerulitis. The contribution of non-proteinuric nephropathy to the global ESKD burden is still poorly focused. In type 2 diabetics, non-proteinuric diabetic kidney disease is more frequent than proteinuric kidney disease. Maintaining a high degree of attention in the care of CKD patients with proteinuria is fundamental to effectively retarding progression. But at the same time, substantial research efforts are still needed to develop treatment strategies that may help the vast majority of CKD patients who eventually develop ESKD via mechanisms pathways other than proteinuria or glomerulosclerosis. So risk factors that might trigger a progressive decline in GFR in the absence of proteinuria or albuminuria include hypertension, obesity and insulin resistance, and high serum triglyceride levels. The glomerular hyperfiltration and alteration is not confined to diabetes, being commonly seen also in early stage of hypertension. So those diabetics who are also hypertensive can also have albuminuria. But if you look at the non-proteinuric or minimal proteinuric nephropathy, these are the major risk factors which has to be given attention along with glycemic control. Now, we did a study way back and published in 2012, study of markers of atherosclerosis, including insulin resistance in patients with chronic renal failure. We divide the patient in 3 groups: non-diabetics with CKD, diabetic with CKD, and healthy controls. And what we found that insulin resistance, beta cell dysfunction, dyslipidemia, CRP, uric acid, and carotid intima medial thickness were significantly higher among CKD patients than controls. This reveals that is a gross atherosclerotic or endothelial dysfunction in diabetics with CKD. Further, there is a greater degree of insulin resistance and beta cell dysfunction in diabetics than non-diabetics. Well, these two pictures can show that if you look at the creatinine clearance and the carotid intima thickness, it has a very strong inverse correlation with R less than 0.75. If you look at CRF and HOMA-IR again, the HOMA-IR also has got, the higher the HOMA-IR, lower was the creatinine clearance. So it's not only proteinuria which is important, other factors definitely play an important role in the manifestation progress of chronic kidney disease and diabetes. Now, coming to reabsorption of albumin escaped from the glomerular filter by the tubulin-megalin complex in renal tubular cells sets into motion a nephrotoxic pathway whereby the complex tubulin-megalin albumin leads to activates the reactive oxygen species synthesis, enhances the synthesis of nuclear factor kappa B controlled cytokine cascade, is a pro-inflammatory cascade, or rather inflammatory cascade, upregulates the endothelin 1 and transforming growth factor B, TGF beta, ultimately leading to tubulointestinal atrophy and fibrosis and renal function loss. Well, this is very important. What are the biomarkers which are predictive CKD? If you look at the glomerular pathology, I beg to your attention to this glomerular pathology. It is cystatin C or alpha-1 microglobulin or beta-2 microglobulin and albumin. If these are present, these biomarkers, that suggests a glomerular disease. When you come to inflammation and damage and to the interstitium, it is alpha-1 antitrypsin, TGF beta-1, then this is monocyte chemotactin protein 1, VEGF, etc., etc. And the proximal tubule, these are the markers. Loop of Henle, osteoponin, and uromodulin are the markers. Distal tubule, osteoponin, and coaptin are the markers, and collecting that copeptin is a marker. So there are a variety of markers which can indicate the damage of the nephrons and the tubular system at different places. We are now only concentrating on albuminuria or microalbuminuria. Now, we did another study, association of nuclear factor kappa B1 gene polymorphism and inflammatory markers in the patient with type 2 diabetes mellitus with or without renal involvement, we published last year. If you look at the controls, these are healthy controls, the type 2 diabetes without nephropathy, and these are with frank nephropathy. If you look, the GFR was definitely much normal, 1.55 here, 2. And there was a slight increase in glomerular filtration here, and here it was 19.21. The VACR was highest in the nephropathy group. And if you look at the urinary monocyte chemotactin protein, it was highest in the nephropathy group compared to the much higher than the healthy controls. Even the diabetics without frank nephropathy also had high urinary monocytic chemotactin proteins. TNF alpha was again highest with the nephropathy group, and diabetic without nephropathy. So these two actually show that is a very pro-inflammatory state involving the tubulointestinal system. Now, looking at the genotype frequency of nuclear factor B1 gene polymorphism, if you look at the insertion polymorphism, it was again highest in diabetic nephropathy group. If you look at the deletion genotype, it was highest in the healthy controls rather than in. So if you have this insertion polymorphism, then it's more likely to be diabetic nephropathy. So this study showed that in diabetics and diabetic nephropathy groups, nuclear factor kappa B gene expression and urinary monocyte chemotactin protein 1 and TNF alpha levels were significantly increased in diabetic nephropathy. Insertion now genotypic polymorphism of nuclear factor kappa B gene were more in diabetic nephropathy group and positively correlated inflammatory markers. And urinary monocytic protein chemotactin factors and alpha and TNF alpha was significantly higher, as I have shown in the table. Now, conclusion: insertion genotype polymorphism increases the risk of nephropathy 2.52 times in diabetic patients in Eastern India. Now, coming to the epilogue, the paradigm shift in understanding diabetic kidney disease. Accumulating data suggests that the proportion of CKD patients without proteinuria is substantial now. In a survey made in the framework of third National Health and Nutrition Exam survey in USA, as many as 37% of patients with EGFR 30 had no albuminuria. I beg your attention to this. It's also true for a condition like type 2 diabetes, where proteinuria was seen as an obligatory step in the pathway conducive to kidney failure has to be revisited. Among patients with type 2 diabetes mellitus with GFR less than 60 millimeter, including the NIANS, 30% were normal albuminuria. So glomerulonephritis are most often proteinuric diseases. The incidence rate of end-stage kidney disease due to glomerulonephritis plateaued in 1990s and since then has a decline steadily. Markers of interstitial involvement leading to non-proteinuric diabetic nephropathy has to be evaluated at an early stage. Strategy for monitoring and management of non-proteinuric diabetic nephropathy has to be established with consensus. More exhaustive genetic study in different population groups will guide us the future management of diabetic nephropathy. Diabetes is the leading cause of kidney failure. Treat diabetes now. Thank you.